The following podcast is part of a certified educational activity titled Achieving Optimal Small Cell Lung Cancer Care with Established and Innovative Therapies, Latest Evidence, Key Ongoing Trials, and Practical Considerations for Real-World Practice. Access the entire activity and complete the post-test at peerview.com/HXN860. Downloadable slides and practice aids are also available.
Good evening, everyone. I'm Dr. Tiziana Leal. Thank you for joining us today. I'm an associate professor. I'm the director of the thoracic oncology program at the Winship Cancer Institute of Emory University in Atlanta, Georgia. And I'm joined today by our faculty and panelists. We have Dr. Mark Awad, who's Director of Clinical Research and Program Director, Advanced Fellowship in Thoracic Oncology at Harvard Medical School. We also have Professor Byung-Chul Cho, Professor at the Yonsei Cancer Center in Seoul, South Korea, and Dr. Carl Gay, Assistant Professor and in the Department of Medical Oncology at the University of Texas MD Anderson. So our goals for today, we're going to be talking about the established and new approved therapies for small cell lung cancer, enhance your awareness of the emerging therapies showing promise in small cell lung cancer, and share some of the groundbreaking results that we saw at ASCO today. And then we're going to also talk about how we can individualize treatment plans, manage AEs, and improve outcomes for patients with small cell lung cancer. LUNGevity is our partner. LUNGevity has survivorship and support services available for patients and their care partners online. Please visit LUNGevity for additional resources. And LUNGevity has a focus on small cell lung cancer. LUNGevity is working with small cell lung cancer experts to create an interactive journey map. And on the right, what you're seeing is LUNGevity partnering to create an advocacy group, the Small Cell Smashers group, through social media, launching this with Dr. Misty Shields from Indiana University. And LUNGevity is very much focused on the patient journey and patient advocacy, and really has created a space so that small cell lung cancer patients can feel heard. So we'll start with our initial discussion. We're going to be talking about how can we optimize the current first-line treatment options for extensive stage small cell lung cancer. So we'll start with a case. This is a 79-year-old female with a past medical history of hypertension, COPD, and hyperlipidemia, 45-pack-year smoking history, who presents with cough and generalized fatigue for 3 months. This patient has an ECOG performance status of 1. Chest x-ray was performed, which reveals a left upper lobe opacity, and then a follow-up CT demonstrates a 4-centimeter left upper lobe mass with left hilar and mediastinal adenopathy. The patient undergoes a bronchoscopy and biopsy that reveals a diagnosis of small cell lung cancer. Additional staging included an MRI of the brain, which was negative, but the PET-CT did show multiple hepatic hypodensities that were hypermetabolic and extensive bone marrow uptake consistent with bone metastasis. She now comes to clinic to discuss further management. So let's talk about the data. Our first trial is the Caspian study. This was a randomized phase 3 study that enrolled patients with treatment-naive extensive stage small cell lung cancer, good performance status. It did allow patients with asymptomatic or treated and stable brain metastasis. Patients were randomized 1:1:1 to 3 arms, as you can see here. Durva plus Tremi, a PD-L1 inhibitor plus a CTLA-4 inhibitor, plus her backbone of chemotherapy, which allowed cisplatin or carboplatin in combination with etoposide every 3 weeks for 4 cycles, followed by durvalumab maintenance. The second arm is durvalumab plus the backbone of carboplatin or cisplatin etoposide every 3 weeks for 4 cycles, followed by durva maintenance. And the third arm was EP every 3 weeks for up to 6 cycles. And in the control arm, PCI was optional. The primary endpoint was overall survival. And we've seen these results in the updated overall survival analysis showing that the addition of durvalumab, the anti-PD-L1 inhibitor, to the backbone of carboplatin or cisplatin etoposide led to improved overall survival in patients in the frontline setting. The median overall survival was 12.9 months versus 10.5 months with a hazard ratio of 0.71. And as you can see in the Kaplan-Meier curves with additional follow-up at the 3-year overall survival update, the 3-year overall survival rate is 17.6% with durva plus EP versus 5.8% with EP alone. This was an exploratory analysis of the Caspian study. They did allow enrollment of patients with asymptomatic or treated brain metastasis. About 10% of patients on each arm had brain metastasis at baseline, 10% in the durva arm, and about 14% in the control arm had prior radiation therapy. And in this exploratory analysis, what it demonstrated is that for patients with or without brain mets at baseline, the overall survival and PFS benefit was maintained. Our next study is Empower 133, investigating now the addition of another anti-PD-L1 inhibitor, atezolizumab, in combination with the backbone of carboplatin etoposide for patients in the frontline setting. Of note here, patients have to have treated asymptomatic brain metastasis, and they only allowed carboplatin. So patients were randomized 1-to-1 to atezo plus carboplatin etoposide, followed by atezo maintenance. And in the control arm, patients received placebo plus carboplatin etoposide, followed by placebo maintenance. PCI was permitted per local standard of care. This study had co-primary endpoints of overall survival and investigator-assessed progression-free survival. We've seen these results, and we've seen the updated analysis of Empower 133, now with a median follow-up of 22.9 months, again demonstrating here that the addition of atezolizumab to the backbone of platinum etoposide led to improved overall survival, with a median overall survival of 12.3 months in the atezo plus chemo arm versus 10.3 months in the placebo plus chemo, with a hazard ratio of 0.76. Additional follow-up with the Umbrella A led us to look at this analysis. Looking at Umbrella A, this was an observational, multi-center observational study that allowed patients on the atezo arm on the Empower 133 to roll over to the Umbrella A extension study. And so patients on the control arm obviously were not included here. And what it showed in a small number of patients, but a glimpse at sort of longer-term survival for patients from the Empower 133, is that the 5-year mark overall survival rate is 12%, which certainly is superior with what we've seen in the past with historical controls, where the overall survival at the 5-year mark is usually less than 5%. Another interesting analysis of the Empower 133 that was done in an exploratory fashion was looking at sites of progression in Empower 133. And I think the sort of noteworthy finding here is that there isn't a significant difference between the two arms, but there was about half of the patients who had progression on target lesion, including in the chest, which led sort of to the rationale and design of a study investigating consolidation radiation in patients with small cell lung cancer in the maintenance setting. That's an NRG LU007 study. And additionally, here is analysis of intracranial progression in Empower 133. Again, this is exploratory in nature. MRIs were not done routinely in the Empower 133 study, but what it does show is that the median time to intracranial progression was delayed in the atezo plus chemo arm versus placebo plus chemo. In addition, we're also investigating new therapies to combine with atezolizumab in the maintenance setting. Lurbinectedin is approved in the second-line setting, and the INFORTE study is now combining lurbinectedin with atezolizumab in this randomized study in the maintenance setting. This study is ongoing with co-primary endpoints of PFS and overall survival. And then thinking about biomarkers for small cell lung cancer, the two studies that we just reviewed led to the approval of immunotherapy in combination with chemotherapy, independent of any predictive biomarker. We looked at PD-L1 and TMB, and none of those were predictive of benefit from immunotherapy in this patient population. The biologic subtypes has emerged as a potential biomarker to predict therapeutic vulnerabilities for small cell lung cancer. These biologic subtypes can be established by differential expression of transcription regulators. And as you can see here, we have identified 3 subtypes, and there's a 4th one called immune-infiltrated, or SCLCI. There has been analysis done in an exploratory fashion of both Empower 133 as well as Caspian to try to identify if there's any differential benefit from therapies according to these small cell lung cancer subtypes. And these subsets appear to, at least in this retrospective analysis, potentially identify patients that have a greater magnitude of benefit from immunotherapy. This is the analysis of the IMpower 133 overall survival, looking at the subset of the small cell lung cancer I or inflamed subtype, demonstrating here an interesting signal of improved or greater magnitude of benefit in the immunotherapy-containing regimen for this subset. And in the exploratory analysis of IMpower 133, there was enrichment of long-term survivors, which was identified as patients living 18 months or longer among the small cell lung cancer I subtype in the atezolizumab-containing arm. But of note, the long-term survivors in the atezo arm were not limited to one specific subset. The benefit was seen across all subtypes. And again, looking at the Caspian, similarly here, looking at the small cell lung cancer I curve, which is the inflamed or the green curves, looking at a differential or potentially a greater magnitude of benefit with the addition of immunotherapy. And another sort of look at this inflamed phenotype is to look at high T-cell inflamed signature. And again, patients with this high T-cell inflamed signature in the Caspian study had numerically longer overall survival. Again, further studies need to be done in a prospective fashion to validate this as a potential biomarker predictive of benefit from immunotherapy in the front line. So let's go back to our case. Our patient with new diagnosis now of extensive stage small cell lung cancer. If this patient comes to your clinic, tell us a little bit about how you would approach this patient and what would be the best management approach, and are there clinical factors that would guide you to use one strategy over another in the frontline setting? I'll start with you, Dr. Gay.
Yeah, so, I think in this case, the patient did not have brain metastases. I think some people will use this as a factor that might distinguish between the Caspian and the IMpower 133 regimen, simply because the Caspian regimen did allow untreated brain metastases as long as they were asymptomatic. That said, in practice, I'm not sure folks are applying it precisely like that. I think people are fairly liberal in their interpretations of it and are using these somewhat interchangeably. And I have to admit that's the way that I approach it as well. And so I think you could justifiably treat this patient with either the Caspian or the IMpower 133 regimen. Also, obviously, I think always in small cell, looking for a clinical trial for these patients where there's clearly room for improvement.
Dr. Awad, any other thoughts?
Yeah, I think this is a very typical case of what we see in our clinics every single day, and it just highlights the need and the limitations that we currently have in terms of early detection of lung cancer, because many patients with non-small cell but also small cell lung cancer really present with widespread or metastatic disease. So certainly we need to have improvements in early detection and interception, but for these patients that are currently presenting, similar to this patient, an older patient, 79 years old with comorbidities, sometimes patients may present with some cytopenias as well that may limit the dosage of chemotherapy, or especially in older individuals where they might not have quite as much bone marrow reserve. We need to watch their blood counts carefully over the course of first-line therapy with chemotherapy in addition to immunotherapy. But I think, in terms of evaluating performance status and whether or not patients can tolerate chemotherapy plus immunotherapy, a question that always comes up is their performance status, mostly limited because of the cancer itself? Small cell lung cancer, is exquisitely initially sensitive to systemic therapy, and therefore this is one of the cancer types where we may, push onwards with systemic chemoimmunotherapy in the hopes of seeing a very dramatic systemic response and improving performance status.
Excellent. Dr. Cho, I'll make it harder. Now the patient has brain mets, bulky hepatic metastasis, and an ECOG performance status of 2. Does that change how you would manage this patient?
I think if a patient had an ECOG performance status 2 due to heavy tumor burden, that means we have to initiate a systemic chemotherapy as quickly as possible. So I think elderly patients and poor performance status doesn't tolerate well to cisplatin rather than carboplatin. So in that case, I would rather choose IMpower 133 regimen compared to Caspian cisplatin backbone. Number one. Number two is I could defer whole brain RT in asymptomatic brain metastasis patient, especially elderly patient. But after 2 or 3 or 4 cycles of induction chemo IO therapy, if patient achieve a major response in the lung as well as the liver, I would rather add some fraction of radiotherapy in the liver, because liver metastasis tell us the patient has a poor prognosis and they may rapidly progress to chemoimmunotherapy, especially maintenance phase. So I would rather add a consolidation radiotherapy in the lung or liver.
Okay, excellent. So let's move on, and I'll hand it over to Dr. Cho to discuss, can we expand the benefits of immunotherapy to limited stage small cell lung cancer?
Okay, thank you. So Dr. Liu talked about anti-tumor synergy between chemotherapy and immunotherapy in extensive stage lung cancers. Now I'm honored to talk about anti-tumor synergy between radiotherapy and immunotherapy in both limited stage small cell lung cancer and extensive stage small cell lung cancer. So this is a typical presentation of a limited stage small cell lung cancer 72-year-old woman, history of hypertension, COPD, and presented with a cough and worsening shortening of breath for 2 weeks. Chest CT scan shows Burkitt right side mediastinal adenopathy, and additional PET CT scan and brain MRI show no evidence of distant metastasis. So key clinical questions are whether adding radiotherapy to chemoimmunotherapy improve clinical outcome in extensive stage small cell lung cancer, and adding immunotherapy to standard care chemoradiotherapy further improve outcome in limited stage small cell lung cancer. So limited stage small cell lung cancer is classified as small cell lung cancer that is generally only in one lung or one side of the chest, and accounts for about 30% of small cell lung cancer diagnosis. How do we treat limited stage small cell lung cancer? Those patients with stage 1, 2, 3A, patient receive surgery followed by adjuvant treatment, whereas those patients with stage 2B, 3C receive concurrent chemo-RT. Due to a rarity of a surgical candidate, majority of patients receive concurrent chemo-RT. Prognosis remain poor for patients with limited stage small cell lung cancer despite curative intent chemo-RT, resulting in only 15 to 30% 5-year survival rate. So, can adding immunotherapy to chemoradiotherapy improve survival outcome in limited stage small cell lung cancer? The answer is yes. Today, we observed great progress in the treatment of limited stage small cell lung cancer. ADRIATIC is a small cell lung cancer version of Pacific trial in NSCLC. Is the first positive phase 3 trial of immunotherapy in limited stage small cell lung cancer. This is a phase 3 randomized double-blind placebo-controlled international study. Patient with a limited stage small cell lung cancer and good eco performance status, who had not progressed following concurrent chemo-RT were enrolled. PCI was permitted prior to enrollment. These patients were randomized to receive durvalumab or durvalumab plus tremelimumab or placebo every 4 weeks until disease progression or intolerable toxicity or maximum of 20 months. The first planned interim analysis of dual primary endpoint of overall survival and PFS by Beaker of durvalumab compared to placebo was presented today at the plenary session. This is a dual primary endpoint of overall survival with a median follow-up of 37.2 months. Median overall survival was 56.9 months versus 33.4 months almost 20 months survival advantage with consolidation of durvalumab compared to placebo. If we look at the Kaplan-Meier survival curve, you can see early separation of the curve, and the gap becomes wider over time. And then if you 3-year overall survival landmark rate was 56% versus 47% in the placebo arm, almost 10% gap at 3 years. This forest plot suggests that consolidation durvalumab provide benefit regardless of all predefined subgroup, including performance status, AJCC disease stage, prior radiation schedule, best response to a prior CRT, and prior PCI. Of note, there seems a more prominent benefit with consolidation chemotherapy in those patients with early administration of durvalumab in the study compared to late administration, as you can see here. This is the Kaplan-Meier survival curve PFS. Again, there was almost 7 months advantage with durvalumab consolidation compared to placebo. This led to hazard ratio of 0.76. 24 months PFS landmark analysis suggests that there is also almost a 10% difference between two arms. Again, PFS benefit was seen across all predefined subgroup. Early administration of consolidation durvalumab seemed to provide more benefit compared to other group, as was shown in the Pacific trial in stage 3 NSCLC. Coming to the exposure and safety summary, as you can see in this table, there is no discernible difference in terms of all treatment emergent adverse event, grade 3, 4, AE, serious AE, and AE leading to discontinuation. This tornado plot compare adverse event over 10% between two arms. As you can see here, overall, as expected, immune-related adverse event in the endocrine organ, skin, is numerically higher with consolidation durvalumab compared to placebo. And however, if you look at the incidence of radiation pneumonitis and pneumonitis, was nearly identical between two arms. So in conclusion, durvalumab as a consolidation two-year treatment of consolidation durvalumab significantly improved OS and PFS compared to placebo in limited stage small cell lung cancer. Hazard ratio for OS and PFS was 0.73 and 0.76 respectively. Treatment benefit was generally consistent across predefined subgroups. So these data really suggest a two-year consolidation durvalumab treatment should be a new standard of care in limited stage small cell lung cancer who have not progressed after chemo-RT. So there are several different ongoing trials. These trials include different immunotherapy sequencing, different combination, and new immunotherapeutic agent. So NRG LU005 study is evaluating concurrent atezolizumab with concurrent chemo-RT. Limited stage small cell lung cancer were randomized to platinum etoposide concurrently with radiotherapy, or same concurrent chemo radiotherapy given concurrently with atezolizumab up to 1 year. The key difference of NRG lung LU005 versus Adriatic is that the concurrent use of immune checkpoint inhibitor, 1 year use of immune checkpoint inhibitor, and lastly, inclusion of ECOG PS2. So here I summarized the other studies, a killing study, also evaluating different combination with pembrolizumab with PUF inhibitor in the maintenance consolidation phase. This is another study, ongoing phase 3 study of tarlatamab, which will be discussed further in detail by Dr. Mark Ward later on. This study for limited stage small cell lung cancer who have not progressed on concurrent chemo-RT, consolidation, tarlatamab, DLL3 T-cell engager compared to placebo. Can adding radiotherapy to chemoimmunotherapy provide benefit in extensive stage small cell lung cancer? That's an ongoing question. So previous studies suggest that consolidation thoracic radiotherapy could provide benefit in extensive stage small cell lung cancer patients who achieve major response following a first-line chemotherapy. However, there is no clear consensus or guideline for TRT, and furthermore, there is limited data on the role of real role of the consolidation thoracic radiotherapy in the era of immunotherapy. So this trial evaluating consolidation radiotherapy in extensive stages of small cell lung cancer, those patients who achieve disease control after following 4 to 6 cycles of etoposide platinum doublet plus atezolizumab were randomized to atezolizumab maintenance as a standard care versus atezolizumab plus standard radiotherapy up to 5 sites. So when we think about addition of radiotherapy, thoracic radiotherapy in extensive stage small cell lung cancer, we have to think about potential toxicity, potential interaction of radiotherapy and immunotherapy in terms of side effect. So this is a multi-center German treasure study. In this study, extensive stage small cell lung cancer who achieve disease control on induction 4 to 6 cycles of chemoimmunotherapy, they are randomized to atezolizumab maintenance versus atezo plus thoracic radiotherapy. So this data was presented last year at ESMO. As you can see here, there is unexpected higher incidence of grade 3 or worse adverse event and serious adverse event and sepsis and higher discontinuation rate with addition of consolidation radiotherapy compared to atezolizumab maintenance. Okay.
So just to kind of remind everyone, this is a patient with limited stage small cell lung cancer. I guess, first of all, within the context of somebody with a new diagnosis of limited stage small cell lung cancer come Monday in your clinic, or maybe Tuesday for you, Tuesday clinic people, what would be your recommendation, and did it change after today? I guess reaction stage radiatic, Dr. Gay.
Yeah, I mean, I think no question there's a new standard of care here. Whether or not the payers will agree as of Monday or Tuesday, I guess, is a matter of debate. But yeah, I mean, I think the data is fairly overwhelming there. And I have patients that are currently completing chemoradiation that I've already forewarned that I'm planning to offer them immunotherapy. I do think that some of the nuances of the other trials that were brought up here will be interesting to see how they play out, like the concurrent immunotherapy options, whether that will lead to better efficacy or potentially worse toxicity using them alongside. Would be excited to see that over the next couple of years.
Dr. Awad, your turn.
Yeah, I think my answer to the question changed from this morning to this afternoon, and it was really exciting to see the Adriatic data. I think we felt that swell of enthusiasm and applause in the audience today, which was always really exciting to see. And so, like Dr. Gay was saying, I was just thinking about a patient after we saw the press release for Adriatic. I had a patient who completed chemoradiation about 4 months ago, and now I'm thinking, how can I help with this patient now? But I think this is a new standard of care. I mean, very impressive improvement in overall survival, median And I think it's great to see that we're advancing care for these patients who up to now and still to a great extent have limited prognosis. I think there are questions about what to do now about prophylactic cranial irradiation, given that patients hopefully are going to be living longer. Will that expose patients to an intervention that may result in long-term neurocognitive deficits? The question about should we even move the immunotherapy earlier to the concurrent chemoradiation phase? We were somewhat surprised when we looked at the non-small cell lung cancer Pacific versus Pacific 2 regimen, where the durvalumab was incorporated into the chemoradiation portion. Will we see sort of similar or different results, which we're not quite sure of? The Pacific 2 moving immunotherapy earlier into concurrent treatment was a somewhat disappointing study, and with theories that you're administering radiation to the immune cells that are potentially influxing into the tumor. Now, small cell may be very, very different. We're not really sure. So I think it's good that we're taking multiple approaches to answer these questions.
I do think it's interesting that in an RGLU005, radiation starts with cycle 2. So there's some debulking going on with cycle 1. Hopefully that could reduce toxicities, and it wouldn't take care of the problem with the potential negative interaction with the radiation and immunotherapy for immune response, but hopefully that could lessen toxicities. But talking about sort of the trials, you mentioned the tarlatamab consolidation trial. I don't see immunotherapy there as an arm. So what's going to happen to
That's
that
the problem. That's the study started right before the data coming out from Adriatic study. So I think enrollment of that study is really challenging in the future. And then I really want to echo previous comment. This is really greatest achievement done in limited stage small cell lung cancer for the past several decades. So this is really, I believe, practice changing. And then I would recommend consolidation 2-year development in all patients who achieve disease control following concurrent chemo-RT and no grade 2 or worse radiation-induced pneumonitis. So I would strongly recommend consolidation immunotherapy.
Yeah, I definitely agree. But let's think about sort of the patient and some of the nuances we saw in the trial and the subset and the subgroup analysis. I saw that there was no difference if cis or carbo was used. Typically, we think of using cisplatin in the limited stage setting. Thoughts about that? What would you use? The second thing was there seems to be a greater benefit if people start sooner. So how do we optimize patients following chemoradiation to get them going as quickly as possible? Any other sort of interesting things? BID versus daily, we thought they were interchangeable before anyway, so that didn't seem to be too much of an issue. But thoughts on those differences or nuances with how we practice and what we saw in the data?
Yeah, I think the big takeaways from the forest plot you hit on, in particular starting early, which we had seen already in the Pacific trial in non-small cell lung cancer and seems to apply here, particularly in that 2-week window. And so you really want to get patients on immunotherapy right away. And I think it does call into question whether beating these patients up with cisplatin is necessary if they have a potentially active drug that's going to come on the back end. The other thing that struck me was you reviewed Empower 133 and Caspian earlier. In both cases, it was a 2 to 3 month improvement in overall survival. Here we're seeing a 21-month improvement in overall survival. Immature data notwithstanding, it's hard to reconcile why these drugs would work or why this drug would work so well in the limited stage compared to how it worked in the extensive stage. And the implications on a very different biology, potentially their tumor immune microenvironment, I thought were really fascinating.
So talking about the subsets, we saw that patients that are limited stage, is it enriched for the subtype that's inflamed? Do you think that could be the reason?
We certainly see. I mean, it's all limited and retrospective, and there's all sorts of caveats that come with this. But when we've independently analyzed limited stage or very early stage tumors versus extensive stage tumors, we do see an enrichment both for the I and the P subtype, and the P subtype is also somewhat inflamed compared to the sort of more highly neuroendocrine subtypes. My pet hypothesis has always been that maybe that's how these tumors remain limited stage to begin with. Like the immune system is the only thing keeping these patients from widely metastasizing very, very early. And so there may truly be a different subtype biology there. It's hard to reconcile these data if they're not, right? Because it's just such a markedly different benefit here.
Excellent. Dr. White, let's take back it to the practical considerations. This is 2 years of consolidation immunotherapy. I mean, when we think about Pacific and rates of who gets through a year of Pacific, and this is generally a population that we tend to have more comorbidities and they may be older, how do you think it's going to go in terms of getting patients through 2 years of durvalumab, and what strategies are you thinking about? I think I recall from the presentation that 33% of the patients completed durva on the durva arm. Is that an issue? What do you think?
Yeah, I think it's a really important thing to kind of lay out the entire treatment plan for the patients now, because sometimes when we first meet a patient, diagnose a limited stage small cell, or in the Pacific case, locally advanced non-small cell lung cancer, a lot of time we focus on the current chemoradiation portion, and patients are thinking about, oh my gosh, I have to come in for daily radiation or twice daily radiation for weeks upon a time and getting chemoradiation, and that takes up a lot of discussion. They're just thinking about how it kind of turns their life up on end for weeks and weeks at a time, and sometimes they forget that after they get through all that, then they're going to have to come in every few weeks for infusions, now for up to 2 years on the Adriatic regimen. And so I think it's important to kind of lay out, and I usually write things out for patients just because it's hard for them and their caregivers and families to recall and retain everything that you discuss when their minds are thinking about many things at once. So I think there are implications. I think conveying that this has not just a statistically significant but marginal improvement in overall survival that can apparently make a major difference in survival. I think most patients will really adopt or see the need why we're continuing such therapy for beyond that. But I do think there are the risks of immune-related adverse events for chronic administration. Sometimes these events happen after the first dose. Sometimes patients are doing very well for 6-9 months, and then suddenly, an immune-related hepatitis or colitis emerges, and we don't really understand the timing of that. So I think especially, we need to discuss with patients and discuss whether this is something that would require earlier discontinuation of immunotherapy due to higher grades of immune-related toxicity.
I think the study still emphasize that the majority of patients discontinue the treatment due to disease progression. The reason why we have a small number of patients who complete trial treatment in the experiment arm is that we still have short follow-up duration. It's only 16 months. So many of the patients in the experimental arm still on the treatment.
I have 2 more questions. One was the magnitude of the survival benefit. We saw PFS of 16 months, and then the OS was like 56 months almost. How can you explain that? Is it just the follow-up issue, or?
I think it's thanks to Dr. Gay and Dr. Howard. They invested a lot of new drug in this field. Number one, major. So I think 7 months PFS benefit and 20 months OS benefit, and then hazard ratio is around 0.7 in both PFS and OS. So I think magnitude of PFS benefit was translated into the similar magnitude of OS benefit. That's my interpretation. I think control arm really outperformed in the trial because the control arm median overall survival was over 33 months. So historical limited stage small cell lung cancer median overall survival middle over 20 months, right? But these patient population live longer, and then experimental arm patients also live longer. And I think if you look at the table, subsequent therapy table, first subsequent immunotherapy in arm A, development arm, only 10%. In the placebo arm, 20% received the first subsequent immunotherapy. Having said that, we have excellent number of median overall survival, meaning that we need to further investigate a second subsequent, third subsequent therapy in this patient population, whether those patients receive investigational treatment that Dr. Award or Dr. Gay are developing.
Excellent. The last one is future directions. How are we going to define immunotherapy resistance, and what comes after if there's evidence of progression?
Yeah, I mean,
after
consolidation, durvalumab, maintenance, progression.
I mean, the tarlatamab study was brought up. I mean, clearly that's going to move sooner. To me, that trial has to be paused and redesigned now, whether or not you need durva in both arms, but at least in the control arm. But you have to think that some combination of BiTEs and or ADCs are going to be coming next, and we're going to move on from the world of kind of just cytotoxics alone. And there'll still be a role for those for sure. So that's a good segue.
So I'll turn it over to Dr. Gay to talk about how can we make the most of the established and new second line and beyond treatment options for small cell lung cancer.
Yeah, so I think obviously a very optimistic day for small cell lung cancer, and there haven't been a lot of those in most of our lifetimes. But the fact remains that most of these patients, even with the outstanding results of Adriatic, will recur and will need subsequent therapies. So let's talk a little bit about what we can do for those patients. So we'll start with a case. We have an 80-year-old female, initially diagnosed with extensive stage small cell lung cancer, treated with a combination of platinum, etoposide, and durvalumab. Completed successfully the induction chemoimmunotherapy with some delays for count recovery, not unusual. Transition to durva maintenance, and unfortunately, like so many of our patients, after 7 or so months on durva maintenance, develop progression of disease, including some new metastases to the liver, as well as a new brain metastasis. That said, good performance status retained and wants to explore other therapeutic options. So let's talk brain metastasis aside for a moment. Let's talk about some of the other therapeutic options that are available in this space. So let's go through a few of these options and sort of the data to support the use of these in the relapse setting, and how that landscape might change in the very near future. And so we'll first touch on platinum rechallenge. This is something that a lot of us had been doing without a great deal of data to support it necessarily for many years. This is a trial here for patients that had at least a 90-day chemotherapy-free interval, which is kind of on the shorter end of what we consider to be platinum-sensitive relapse small cell lung cancer. These patients were randomized to receive either retreatment with a platinum-based regimen or topotecan, which is one of the other standards of care in the relapse setting. You can see in the PFS curve on the left there that the retreatment with platinum did afford these patients a longer progression-free survival, hazard ratio of less than 0.6. Did not translate into a meaningful difference in overall survival. Those curves hug one another. But certainly if you need a response and you're looking to keep these patients progression-free, which I think is a valiant cause in this setting, it's, I think, totally reasonable to retreat with platinum. This is also being done in an era where we had very few options, right? You were sort of alternating between either platinum rechallenge or maybe topotecan. Topotecan is kind of has an interesting story with its role in small cell lung cancer in that it's never really bested anything head to head. It was, not to rag on topotecan here, but it's, it was superior to best supportive care in overall survival, which is something, but, head to head against CAV, a regimen not used particularly frequently in the United States, an anthracycline-based regimen, but used worldwide more frequently, is about the same, but perhaps a little bit better tolerated. Topotecan has the downside of having to be given 5 days in a row, right? And so there's some logistical challenges that come along with topotecan. Lurbinectedin, a relatively recent addition to our armamentarium for relapsed small cell lung cancer. The mechanism of action of lurbinectedin, I think, is more complex, perhaps, than some of the other cytotoxic agents that we use in small cell and lung cancers overall. I think the most common mechanism cited is that it's an inhibitor of transcription. Small cell lung cancer, under a lot of replication stress, a very transcriptionally active disease, and so not surprising that lurbinectedin would be active here. This also seems to be a pro-inflammatory effect of lurbinectedin that may offer some hints at synergy with immunotherapy. The ultimate approval of lurbinectedin in relapsed small cell lung cancer emerged from this phase 2 basket study that included a small cell lung cancer basket. These were previously treated small cell lung cancer patients with PS ranging from 0 to 2, which I think is a good range for a relapsed small cell lung cancer trial, and included patients that had prior immunotherapy. And I think the results here are broken down again based on chemotherapy-free interval, and again using the 90-day cutoff, which is the lower end of platinum sensitivity. And what they found was that patients that were platinum sensitive, that had greater than 90 days chemotherapy-free interval, did quite a lot better than those that were platinum refractory. If you look down at the at some of the overall or objective response data, the patients that were chemotherapy-free for more than 90 days had about double the response rate, 46% versus 22%. Also improvements in PFS and in OS seen in that population. This is a population that probably has a little bit better prognosis overall. But at the time, these sorts of response rates were unheard of in the relapse setting. Obviously, there have been a few new trials that have come out recently that are at or near these. But this was a very welcomed addition at the time in a world where we had basically topotecan and off-label agents. Lurbinectedin toxicity profile, similar to what we've experienced with other chemotherapies, and so I think nothing that required really re-education for thoracic medical oncologists. We see cytopenias, we see some fatigue, some nausea, but there were not a lot of sort of lurbinectedin unique toxicities that were observed here. The phase 3 Atlantis trial, I guess ostensibly the first effort to secure lurbinectedin's role in the relapse setting, although there are several caveats here. The lurbinectedin dose is lower and used here in combination with doxorubicin rather than as a monotherapy. So it's been giving it 2 mg per meter squared instead of the 3.2 mg per meter square. And then this is being compared to either topotecan or CAV, kind of investigator's choice. This did ultimately not show that lurbinectedin in combination with doxorubicin was superior to the investigator's choice between CAV and topotecan. However, there were some interesting takeaways. So these patients were allowed to continue the combination up to 10 cycles and then could go to the higher dose of lurbinectedin, the 3.2 dose at that point. And in the diagram in the bottom left there, you can see that some of these patients who had only stable disease, for example, up until that point, when the lurbinectedin dose was increased, they actually had some responders there. There were some patients that actually experienced greater responses after they'd completed 10 cycles, which is kind of hard to imagine, right? It's a pretty cytotoxic regimen that they were on, and suggesting that maybe the discrepancy in the lurbinectedin dose was relatively critical to the relative inefficacy seen here. And so there is the Lagoon study, which is ongoing, which I think will be the real opportunity to confirm lurbinectedin's place here. And so this is a 3-arm study, including the lurbinectedin at the 3.2 dose that I've mentioned several times, a lurbinectedin 2.0 mg per meter square plus a irinotecan arm, and then again, sort of an investigator's choice, topotecan or irinotecan. It'll be really interesting to see this readout. I think one promising hint comes tomorrow from Dr. Paz Ares, showing some of the preliminary efficacy of lurbinectedin plus irinotecan. And here, particularly in those patients that had long chemotherapy-free intervals, 90 days or more, seeing responses over 60%. Again, this is in a range where we've just never seen in relapsed small cell lung cancer, even when you subdivide them based on something like chemotherapy-free interval. Anything inching above the 50% response rate is fairly unprecedented territory. And now we're fortunate enough, and you'll hear about, I think, essentially all of these, to have several agents that have shown early signs of response rates in and around that range. I think the other one of the other major players in the space, and I think the audience seems to recognize that based on their their pull response is DLL3 T-cell engagers. So there are a number of these that are already approved in the case of tarlatamab or are under investigation. This is a cartoon illustrating a few of those. So tarlatamab, it sounds like most folks are familiar with. Bispecific, the drug from Boehringer Ingelheim. BI 764532 is another bispecific. There's also a trispecific from Harpoon, which includes, in addition to the CD3 and DLL3 targeting antibodies, an anti-albumin component, which is intended to extend its half-life. The mechanism of action here is similar in these and the others that you'll see. Basically, you have an antibody that's attracted to something on the surface of the tumor cell, in this case DLL3, and then an antibody that's attracted to CD3 on T cells, sort of forces an interaction. As we've talked about already, small cell lung cancer tends to be an immune desert, and so getting T cells to the microenvironment is quite a battle to begin with, and so this serves to sort of brute force that. So we've seen earlier phase 1 data from tarlatamab, and then more recently the Delphi 301 study with tarlatamab. This is a cohort of small cell lung cancer patients that have had at least 2 prior lines of therapy, so pretty heavily pretreated, pretty poor prognostic population, randomized to receive tarlatamab at either 10 milligrams or 100 milligrams. And then a dose expansion ultimately done in 10 milligrams, which seems to be the dose that's moving forward so far. We'll focus on that 10 milligram cohort. The objective response rate there, 40%. I think more impressive probably than the objective response rate is the depth of some of the responses that you can see in the waterfall plots in the top right, and then especially the duration of responses. They're seeing many responses that are out beyond a year, and a median overall survival in that 10 milligram cohort of 14.3 months. And if you all think back to Dr. Liao's initial slides here, the overall survival in the frontline setting is 12 to 13 months, depending on whether you're looking at Empower 133 or Caspian. So these patients are actually living longer than untreated frontline patients have historically. And so that's really heartening to see that if you bring the immune cells to the tumor, you can actually generate anti-tumor immune responses. This is just some of the PFS data between the two cohorts. I think the big differentiator between the 10 milligram and the 100 milligram doses, there wasn't a lot of difference in terms of the response rate. Was a little higher in the 10 milligram, but overall it was pretty similar. I think the safety was the major factor here. The 100 milligram dose seemed to be a little bit more toxic. I just want to pause a minute to think about the safety, because I think this is, at least for somebody that's solid tumor only, a thoracic medical oncologist, this is a little bit of a brave new world for us. We're not used to battling with cytokine release syndrome. I think fortunately for all of us here in the room, the cytokine release syndrome seems to be quite mild. The rates of grade 3 and above cytokine release syndrome and the 10 milligram dose, essentially nil. There were some mild cytokine release syndrome, the sort of thing that you can often manage with acetaminophen and some IV hydration. There were some dose interruptions and dose reductions that happened in this trial due to some of the toxicities. I think the other positive thing is if you can get through, so they're doing a step-up dosing, if you can get through the day 1 and day 8 dosing to get up to the full dose, the likelihood of any toxicity after that seems to be effectively zero, at least sort of the cytokine release ICANS type toxicity. But I think this is going to take some getting used to in managing these toxicities among all of us, right? And we're going to be leaning on some of our cell therapy colleagues at our respective institutions. Obviously, tarlatamab was just recently FDA approved. These are exciting times in small cell lung cancer, right? A plenary, a recent FDA approval. It's a fun time to be giving a talk like this. There was data just shown literally right before this session, about 2 hours ago at this point, showing tarlatamab in patients, because the trial did allow patients to have brain metastases, and they did not see any particular signal to suggest that this was a bad idea to give tarlatamab. I think because of ICANS, because of the neurologic side effects that can arise from bites and CARs, there was some concern that there might be more toxicity in this group. Doesn't seem to be the case. The objective response rate actually a little bit higher in the brain mets patients, but a small number of patients, right? I think the takeaway here is that you can probably use this perhaps not in somebody that had, rip-roaring symptomatic brain metastases, but at least a patient that had, asymptomatic small brain mets. I mentioned there were a couple of other DLL3 bi and tri-specific agents that were that are under investigation. I'll just briefly go through the data and some of the nuance in those trials here in the next few minutes. BI 764532 rolls right off the tongue. And so we have phase 1 data for this. The unique part of this trial, I guess, is twofold. One, it required DLL3 positivity by IHC to enroll. In the tarlatamab studies to date, they've not really shown that there's a strong correlation between DLL3 expression, and they find that most tumors are at least a little bit DLL3 positive. And so there's probably some question as to whether or not this screening is necessary. And this also allowed patients that had other high-grade neuroendocrine carcinomas like large cell of the lung and extrapulmonary neuroendocrine carcinomas. These are the waterfall plots for those cohorts, small cell, extrapulmonary neuroendocrine carcinoma, and then pulmonary large cell. You see activity across these in small cell objective response rates about 26%. That's comparable to what the phase 1 for tarlatamab showed. This is restricted to just the patients that received what they think to be kind of an efficacious dose of greater than 90 micrograms per kilogram, and also saw activity in the extrapulmonary and large cell, which are not the topic of discussion here, but are really diseases for which there's not enough trials and not enough treatment options. Harpoon with their drug HPN 328. This is the tri-specific that includes the anti-albumin, so that potentially it could be dosed at a slightly more favorable or more convenient schedule. Here, this trial included, again, not only small cell lung cancer, but also high-grade neuroendocrine carcinomas that were DLL3 positive. Small cell did not have to be DLL3 positive, and also neuroendocrine prostate cancer. And this is the waterfall plot here. The confirmed response rate, 31% across these cohorts. And so, again, pretty impressive activity for early phase clinical trials with a new class of agents. So I think not a whole lot so far to distinguish these agents in terms of activity. And so I think it will, will come down to kind of developmental plans, perhaps, as to where we go. There are a number of ongoing trials, several agents that I haven't mentioned here because we don't have data, including the tri-specific from Roche that includes a CD137 antibody, which should help to kind of further stimulate immune activation and anti-tumor immunity. And so really interesting to see where this field goes over the next 3 to 5 years, I think, as some of these move earlier into the space, and then we attempt novel combinations to see what we can do with this class of agents. I'll just speak for just a moment here about CARs, chimeric antigen receptor T cells. The experience with these is relatively limited. We treated 5 patients at MD Anderson on this study before the study was closed down, I think, to focus on the success of tarlatamab, because this is also from Amgen. But there were early signs, even at a very, very low dose with this CAR, of activity, particularly in relapsed small cell lung cancer patients that had DLL3 expression. So of the 5 patients treated, 3 by IHC were DLL3 positive with any sort of DLL3 expression at all. And all 3 of those patients experienced at least some tumor reduction, and one of them had a confirmed PR. And so obviously there are challenges that come with using a CAR that are not necessarily present with a bispecific. And so I think a CAR would have to be not only as good, but probably better than a bispecific in order for there to be uptake, within the treating market here. But I think just the notion that an otherwise immunologically inert tumor can respond to things like BiTEs and CARs, really interesting proof of principle, because as you'll hear in Dr. Awad's portion of the talk, these are not the only cell surface targets that are available for small cell lung cancer. And so we can really go nuts with drug design here. So just returning to the case, again, this is a now relapsed extensive stage patient with brain mets progressing on after about 7 months on durva maintenance, and talking about what we would do here. So I'll turn it back over to you for the discussion, Dr. Leo.
Okay. So let's go back to our patient. So now this patient is 7 cycles of maintenance. What is the optimal second line option within all of the options that we saw in that polling question? So Dr. Awad, how do you think about it? Are there patient-specific factors? Are there, other factors related to perhaps the care center patient support that would help you and your patient choose what is the best next therapy?
Yeah, I think it's very nice to see that there are emerging options for patients with relapsed or progressive small cell lung cancer, because up until recently, our options were really quite limited. And I think what Dr. Gade nicely highlighted is the potential for long-term benefit with some of the newer classes of agents like tarlatamab. And I think, along with our immune checkpoint inhibitors, which we know only benefit a minority of patients with solid tumors. However, despite that, we know that if you are one of the lucky responders to immune checkpoint inhibitors, there's the potential for really durable and long-term responses. And I think that's kind of the sense or the feeling with drugs like tarlatamab also, is that we don't necessarily know what the right biomarker is or who the patients are that are going to respond best to the DLL3 T-cell engagers, but we are seeing, very impressive overall survival and durable responses in subsets of patients. So I think, we definitely want to give our patients the best chances. And so I may agree with, the general audience sense of using tarlatamab as a preferred agent. We can always, quickly pivot to trying to use other agents, retreating with platinum etoposide or using topotecan or others. But, the tough thing with small cell lung cancer is sometimes if patients are progressing on one line of therapy, they can have a rapid clinical deterioration to the point where they're not able to get to the next subsequent therapy. So that's where, you have to be very, judicious about what your choice is, because that might be your only, next option for the patients. I think, not unlike what we're seeing in this case, sometimes when patients progress, they also progress in the CNS, and we need more information and data to know, what is the CNS efficacy for some of these novel systemic therapies, including some of the DLL3 T-cell engagers. So, I think where we see patients with progression both in the CNS and systemically, often we're trying to figure out, which fire do I need to put out first? When do we incorporate radiation therapy? Do I need to use radiation to the CNS now and then start systemic therapy later, or am I going to get into systemic trouble if I delay systemic therapy? So it's a big discussion with the patient with radiation oncology, and sometimes we start systemic therapy, we integrate radiation if they're not having a CNS response, or we try to weave it in between cycles of therapy. So it is challenging, and it often involves multidisciplinary discussions.
So what would you do for this patient?
Well, I think probably it sounds like there's not really symptomatic brain mets. I might try tarlatamab and close monitoring of the CNS in parallel. But in parallel, I would definitely refer the patient to radiation oncology, such that they can meet the patient, get to know them, and integrate radiation to the CNS as quickly as possible if we get into trouble. There have been some trials in the radiation oncology field about whole brain radiation therapy versus SRS. Typically the teaching and the standard has been using more whole brain radiation therapy with small cell lung cancer brain metastases, but we know that is not without its short-term and long-term side effects. So I think there are emerging options for managing the CNS progression as well.
And I guess the next question is, you've made the decision for tarlatamab. Is this patient in the community or in an academic setting? What do you see that looking like as the FDA approval and patients are talking about it? Clinicians want to use this new treatment. And do you already have sort of a workflow at your own institution for initiating tarlatamab in clinic next week?
Yeah, this is one of the questions that I saw had come through, and I think this is burning in all of our minds. I mean, I think probably several of us are fortunate to have sort of developed a pseudo workflow from being involved in some of the trials. But on those trials, we were typically admitting like 1 or 2 patients a month. We see many, many more relapsed small cell lung cancer patients than that, and it's hard to imagine the inpatient bandwidth being there, even if it's just 24 to 48 hour monitoring. And so I think there's going to be a little bit of a learning curve. I think these patients are probably going to initially be referred into academic centers to get the drug, and that's going to lead to a little bit of inequity in who has access to this drug, probably for the foreseeable future, and that's disappointing. The CRS is real, but pretty mild. And so I think there's optimism that we'll get to a point where this is being managed as a routine outpatient rather than a 24-hour inpatient with tocilizumab on hand, which is a lot to ask of community centers.
I think oncologists are good at trying to quickly get up to speed with new and emerging therapies. I think we saw this with the first wave of immune checkpoint inhibitors. How do we manage colitis and pneumonitis and hepatitis, et cetera? And I think most people have comfort with that. I think there's now TIL therapy for melanoma that may extend to other solid tumors. So I think we're quickly having to learn these new classes of medication and how to manage their side effects and safely administer them.
And I think one additional sort of question that is coming up is, our preferred second line had been lurbinectedin, and now we're seeing, okay, there's a lot of enthusiasm with tarlatamab with all the challenges of still needing to work out the workflow and access and safety in the community setting and in the academic setting. Will lurbinectedin be third line then? And what happens if the INFORTE trial is positive when we're using lurbinectedin in maintenance?
I mean, I think that there'll probably be sort of 2A and 2B initially. I think there are going to be some logistical hurdles that probably still result in folks opting for lurbinectedin. The data for tarlatamab is really exciting, but still the majority of patients do not respond. And with a BiTE, you kind of expect it to be kind of either you respond or you don't. There's probably not a lot of in between without any cytotoxics on board. And so if you had a patient that was rapidly progressing, you might still opt for something that might offer an immediate cyto reduction rather than, kind of going for the upside of tarlatamab, I suppose.
There's a question here regarding sub-Q tarla, like what we saw with the sub-Q AMI.
That study is coming. And so I think we all agree that would make everybody's life a lot easier, although I think it's going to be a little different than AMI. That's an infusion reaction that the sub-Q essentially eliminates. Here, I think there's still the potential to get some CRS with the sub-Q. Would be the safety from that trial is going to be very interesting to see.
And then one last question. You were mentioning, tarlatamab got approved independent of DLL3 expression biomarker selection, and we're seeing BI have a strategy of identifying patients based on biomarkers. How do you think that'll play out if it does get approved based on biomarker selection? What would people use and what would people prefer?
I don't think there's any indication that DLL3 high versus moderate or low really is the be-all, end-all biomarker here. I think there are two ways this can go, right? It could be target expression, or it could be sort of the hospitality to the T cell that's introduced. And some small cell lung cancer is just not very hospitable to T cells, right? They're an immune desert for a reason. And so I would not be surprised if the biomarker turned out to be sort of somewhere in between. A slightly inflamed tumor that also has some DLL3 might be optimal. That's going to be very difficult to have an easy, quick biomarker for, I think, as opposed to just like what we have in breast cancers or things like this for ADCs and certain drugs like this.
Very good. Let's move on to our last session. I'll turn it over to Dr. Awad to discuss assessing the potential of emerging therapies for small cell lung cancer, focus on the ADCs.
Great, thank you so much. So I think, we're in an exciting era where we're seeing a lot of drug development, which is terrific. And in the subject of antibody-drug conjugates, which is a very hot topic in lung cancer in general across many tumor types, we're seeing some early signals of activity in small cell lung cancer, which I think is extremely encouraging, however, still at this very early stage. So I think we've been talking about ADCs for several years. We don't have any approved in small cell lung cancer to date, but of course we've got approvals for non-small cell lung cancer with trastuzumab deruxtecan in HER2 mutant lung cancer, and of course ADCs approved in breast and other malignancies. So again, just broadly speaking, how these ADCs differentiate themselves from one another is with the antibody, the linker, and then the drug or the payload. So the antibody is what will bind to various cell surface targets. We have the linker, which gets cleaved during administration, and then the drug or payload, which can be any of a variety of mostly chemotherapeutics, although there are some efforts to develop other such payloads that perturb, say, apoptosis or other such pathways. But most of the payloads to date have been I would say microtubule inhibitors or topoisomerase 1 inhibitors in most of the development that we've seen so far. So the ADCs have several proposed mechanisms of action, as shown here, broadly speaking. So there is some antibody engagement leading to payload-independent anti-tumor activity. So this is antibody-dependent cytotoxicity, where the Fc portion of the antibody can stimulate an immune cell response or disrupt receptor dimerization. Most of the antibody-drug conjugates get internalized into the tumor cells upon binding to their targets, and there the payload gets released from its linker through the endosomal or lysosomal pathways, and upon release is when these cytotoxic payloads can affect their damage in a variety of ways depending on their mechanism. And then there's also the thought that the payloads can enter neighboring cells as a somewhat bystander effect upon release into tumor cells, as shown here. The ADCs can also differ by what's called the DAR, or the drug-to-antibody ratio. And so in addition to the antibody, the linker, and the toxin, there can be a different number of toxins that are linked to each antibody. So in this example of DM1 or mtansine, in this cartoon, there's a drug-antibody ratio of 3. So you can see here 3 drugs per 1 antibody. In this example of trastuzumab deruxtecan, or TDXD, which is also called Enhertu, this compound has a DAR, or drug-antibody ratio, of 8 with 1 antibody and 8 toxins. And there's different thoughts here. There's different ranges of drug that can be linked to the antibody. More is not necessarily always better per se. There is some leakage or release. We hope that most of the toxins do get released intracellularly into the tumors, but there can be some release of these toxins during systemic administration, which may be responsible for some of the systemic or off-target effects and toxicities that we see with this class of drug. So what are the data and some of the emerging ADCs that have been tested in small cell lung cancer? So again, a fairly limited data set, but again, early signs of activity and signal here. So IDXD, or ifinatamab deruxtecan, DS7300A from Daiichi Sankyo, is a B7H3 antibody drug conjugate, IgG1 here. And again, as we've seen with other, especially Daiichi compounds that have a deruxtecan linker, this is a topoisomerase 1 payload that is linked by their tetrapeptide-based linker. And ideally, this is cleaved during intracellular uptake by tumor cells. And there's been a dose escalation study, part 1. You can see here different doses, 8 mg per kg, 12 up to 16, followed by dose expansion cohorts, which have since been expanded. The initial expansions were in squamous esophageal cancer, castrate-resistant prostate cancer, and squamous non-small cell lung cancer, with an initial thought of perhaps some enrichment in B7H3 expression in squamous histologies, although I think more broadly since then, there's been a recognition that this class of drug and these B7H3 ADCs can work beyond these tumor types, and hence the expansions in small cell lung cancer. And so you can see here in some of this initial reporting, just in the small cell lung cancer cohorts, in the different dosing levels, 6.4, 8, 12, and 16 mg per kg, you can see a nice downward fall of this waterfall plot with a response rate, again, in a small number of patients, 21 patients, but response rate in excess of 50%, which again is encouraging for our patients, median PFS of 5.6 months. I think, one caveat that just to be mindful of is there have been a lot of drugs over the years that initially show some response or efficacy in small cell lung cancer, but can unfortunately be short-lived or quite limited. And so I think we definitely need to see in a larger cohort of patients in longer follow-up. And again, some of these doses may be at too high of a level for broad tolerability. So, but again, many of these patients had a number of prior lines of therapy. This is a very enriched patient population of small cell lung cancer. for a small cell patient to receive 1 to up to 7 prior lines of systemic therapy, that is an enriched population of often, better performing patients that have the luxury of getting on to a phase 1 study. So we'll have to see as these trials expand how these response rates and duration of responses play out. Again, a big question is the biomarker for selection, and I think this is really underdeveloped for the ADC field. I think in general, a lot of ADC trials, broadly speaking, in solid tumors are moving rapidly in an all-comers population without an enrichment strategy. I think, the one ADC we have approved for lung cancer is in HER2 mutant lung cancer, where there's a very predefined but uncommon cohort of patients, but a high response rate. And I think we hopefully will be able over time to recognize and identify what are the patient populations that really benefit from B7H3 targeting ADC. Here you can see in one, again, small correlative analysis about looking at the H-score of B7H3 expression by immunohistochemistry or other potential such ways of quantifying this that, again, it hasn't been very clear as to, in these very, very small cohorts here, again, we have to be careful here. There's 2 patients, 4 patients, 9 patients here that, we don't have a sense yet whether correlation exists between higher expression in those patients that respond to therapy and lower expression in those patients with primary progressive disease or stable disease. But I think this is an important parallel track that we need to identify as these trials are moving along to try to understand who are the patients that do or don't benefit. As I was mentioning, sometimes you only have 1 or 2 shots of systemic therapy in small cell lung cancer, so you don't really want to waste time for patients to receive an ineffective therapy. So ideally, we would need to know and want to know, who should be getting DLL3 targeting therapies, who should be getting B7H3 ADCs and others as we can develop biomarker enrichment strategies going forward. Again, generally speaking, in this early phase 1 study, you can see here across the different tumor types, and in total, you can see the broad safety summary as shown here. And so in about 8% of patients, you can see treatment-emergent adverse events with drug discontinuation, about 1/5 of patients with drug interruption, and 10% of patients with dose reduction. So as we'll see going forward, how they'll settle on a dose for expansion and moving forward into larger patient populations. And this will be tested in planned phase 3 study in small cell lung cancer after 1 prior line of platinum-based therapy. And again, we'll have to see how to put these trials in context with one another, since this is, an exciting and we haven't been used to having trials, compete with one another in small cell lung cancer since we've been kind of knocking our head against the wall for, decades. But it's exciting to see a various number of approaches underway. But this is a trial in patients where they'll get randomized 1-to-1 to receive the B7H3 antibody drug conjugate or DS7300A versus topotecan, erubicin, or lurbinectedin, which again may not be a standard next line of therapy in the coming years. So this trial may need to be adapted depending on some of the data that we hope to emerge in the coming months and years. At this ASCO also, we've seen data on CES6 targeting antibody drug conjugate. So this, again, targets CES6, another surface protein conjugated to a topoisomerase 1 payload, as shown here with a drug-antibody ratio of 6 and a stable cathepsin cleavage linker as demonstrated here. So this is ABBV706, similar mechanism of action binding to CES6, so a different cell surface target, and again, somewhat limited amount of information or data on how often these targets are expressed in small cell lung cancer, how often they are co-expressed with B7H3 or DLL3. But here we see a monotherapy study design in dose escalation focused on a cohort of small cell lung cancer as demonstrated. And here we can see that in relapsed or refractory small cell lung cancer, 23 patients, again, we're seeing a response rate of 60.9%, which again, a clinical benefit rate of 91%. So very, impressive, although still quite early on in this analysis. You can see here 11 of 18 patients with available chemotherapy treatment-free interval data were platinum resistant, because again, we're learning in various studies that in some cases, if you don't do well with first-line therapy, that portends worse responses to subsequent lines of treatment. But again, it can be encouraging that we're seeing activity in both patients that are more on the platinum-resistant or platinum-sensitive side of things here. We're seeing trials move forward with TROP2. Of course, there's been a lot of interest and swings of enthusiasm with TROP2 targeting in lung cancer. We've seen a lot of trials move forward in non-small cell lung cancer, but now these are also moving forward in small cell as well. Again, it's not clear that expression, at least as measured by immunohistochemistry, is a predictive biomarker for ADCs in general, but we do know that TROP2 can be expressed in a proportion of high-grade neuroendocrine tumors, including small cell lung cancers, and that is the basis of trying to advance these TROP2 ADCs in small cell lung cancer as well. We've seen efforts with sacituzumab govitecan, and again, these are somewhat older studies or older data. And this was a trial that was testing sacituzumab in triple-negative breast cancer, as well as other tumor types, urothelial, non-small cell, and small cell lung cancer. Again, we've seen data at this ASCO on sacituzumab from the EVOKE-01 study in non-small cell lung cancer, somewhat disappointing, but we'll see if this is a more promising agent or strategy targeting TROP2 with ADCs in small cell lung cancer. But again, we see a response rate of 18%, duration of response of 5.7 months among a cohort of 62 patients. Again, just breaking down the patient populations here in all patients, as well as those receiving the 10 milligram per kilogram dosing strategy here. And again, smaller numbers of patients, but a response rate of 17%. So modest response rate here, but again, just some proof of principle that there are a portion of patients with small cell lung cancer that can potentially respond to TROP2 ADC targeting strategies. We've also been seeing trials move forward with datopotamab deruxtecan, again from Daiichi Sankyo, in small cell lung cancer, and we hope to see activity for this patient population. So somewhat limited data, but an initial signal of encouraging efficacy in this population. And I think what we are really looking for is, what are the subsets of small cell lung cancer that should be treated with these various ADCs? Will we be able to help steer patients in a more precise precision medicine fashion to the right drug at the right time? How will these ADCs need to be optimized in terms of their potency, payload, drug antibody ratio, the properties of the linker and cleavage? These ADCs have differences in toxicity. Of course, interstitial lung disease pneumonitis is a very feared toxicity in this patient population who already has a lot of compromised lung function. So we'll really need to identify what are the risk factors for various of these toxicities and how do we manage them safely and effectively for our patients.
Okay, that was excellent. I will say I think the biggest challenge is, as we think about will we personalize therapy for small cell lung cancer, I mean, that usually has to do with biomarkers. And we just heard that all of the newly developed treatments that have come to approval are in an all-comer population. So how do you see that with ADCs? You just showed us 3 potential different targets, no biomarker to select. How should we integrate this into practice if more than one ADC gets approved?
I think it's a good question, and I think in many cases there is limited tissue availability for testing multiple biomarkers in parallel, and so sometimes depending on region of the country in the U.S. or region of the world, there are some interventional radiology practices or otherwise that, are reluctant to do, for example, a lung biopsy just because of the risk of pneumothorax. So I think often we are, in some cases, struggling to have just enough tissue. We have enough just to make the diagnosis of small cell, but depending on the type of assay that needs to be performed, we don't want to be exhausting tissue doing an IHC for DLL3 and an IHC for SEZ6 and an IHC for B7H3. And right now, there's not really a clear sense that that's the right test for optimizing and identifying patients. And so can we somehow do a more multiplexed or RNA-based assay or otherwise to really kind of help direct and steer patients? Can we use more non-invasive or blood-based tests looking at circulating tumor cells, which are able to be found in small cell lung cancer more so than in other lung cancer types? And could that be a way that we can maybe identify markers of response to these therapies? But I'll also turn it over to Dr. Gay with expertise in this topic.
Yeah, I mean, I think you're exactly right. The iterative IHC is not going to be functional here unless we totally change the way we biopsy these patients. And the other point that you made, which is that, if we have 3 or 4 of these come to market and we're lucky enough to do that, if a patient doesn't respond to one of them, you're probably not going to get a chance to give them the others. And so you really need to know which one they're at the highest likelihood of benefiting from. I think your comment about plasma-based assays, I'll just add to that I think even methylation in the ctDNA could offer insight in a multiplex fashion of expression of these, if expression of these targets turns out to be important. But it'll be a good problem to have multiple ADCs in the small cell space, but I think a problem all to see.
Excellent. Thank you, everyone.
Thank you for listening. Remember to download the slides and practice aids and complete the post-test for instant credit. This activity is certified by PVI, PeerView Institute for Medical Education. This activity is developed with our educational partner, LUNGevity Foundation. This activity is supported by independent medical educational grants provided by Amgen, AstraZeneca, Daiichi Sankyo Incorporated, and Jazz Pharmaceuticals. To access all materials for this activity, visit peerview.com/HXN860.